May I come in?
Yes.
Hello.
Hi. My name is Mansi Gawali, one of the medical student. What is your name?
My name is Madhukar.
Okay. And what is your age?
38.
So today we are going to do a physical examination of your cardiovascular system. We'll start by identifying your jugular venous pressure.
May I remove the mask?
Yes, you can.
Estimating jugular venous pressure is one of the most important and frequently used skills of physical examination. The jugular venous pressure is best assessed from the pulsations in the right internal jugular vein, which is directly in line with the superior vena cava and right atrium. The internal jugular veins lie deep into the sternocleidomastoid muscles in the neck.
To measure jugular venous pressure, we'll need a rectangular object, a torch, and a centimeter ruler.
Make the patient comfortable. Raise the head slightly on a pillow to relax the sternocleidomastoid muscles. Raise the head of the bed or examining table to about 30 degrees. Turn the patient's head slightly away from the side you are inspecting.
Use tangential lightning and examine both sides of neck. Identify the external jugular vein on each side. Then find the internal jugular venous pulsations.
Focus on the right internal jugular vein. Look for pulsations in the suprasternal notch between the attachments of sternocleidomastoid muscle on the sternum and clavicle, or just posterior to the sternocleidomastoid muscle. Distinguish the pulsations of the internal jugular vein from those of the carotid artery. Identify the highest point of pulsations in the right jugular vein. Extend a long rectangular object or card horizontally from this point and a centimeter ruler vertically from the sternal angle, making an exact right angle. Measure the vertical distance in centimeter above the sternal angle where the horizontal object crosses the ruler and add to this distance 5 centimeter, which is the distance from the sternal angle to the center of the right atrium. The sum is jugular venous pressure. Next, examine the carotid pulse, including the carotid upstroke, its amplitude, the contour, and the presence or absence of thrills or bruits. To assess amplitude and contour, the patient should be supine with the head of the bed elevated to about 30 degrees. First, inspect the neck for carotid pulsations, often visible just medial to the sternocleidomastoid muscle. Then, place your index and middle fingers or left thumb on the right carotid artery in the lower third of the neck and palpate for pulsations. Avoid pressing on the carotid sinus, which lies adjacent to the top of the thyroid cartilage. For the left carotid artery, use your right fingers or thumb. Never palpate both carotid arteries at the same time. This may decrease blood flow to the brain and induce syncope.
Now we'll identify your brachial artery.
Okay.
The patient's arm should rest with the elbow extended, palm up. Cup your hand under the patient's elbow or support the forearm. You may need to flex the elbow to varying degree to get optimal muscular relaxation. Use the index and middle fingers or thumb of your opposite hand for palpation. Feel for the pulse just medial to the biceps tendon. For the cardiac examination, stand at the patient's right side. The patient should be supine with the upper body and head of the bed or examining table raised to about 30 degrees. Inspect the anterior chest, noting any heaves or lifts. To palpate heaves and lifts, use your palm and or hold your finger pads flat or obliquely against the chest. Heaves and lifts are sustained impulses that rhythmically lift your fingers, usually produced by an enlarged right or left ventricle or atrium, and occasionally by ventricular aneurysms. For thrills, press the ball of your hand firmly on the chest to check for a buzzing or vibratory sensation caused by underlying turbulent flow. The apical impulse represents the brief early pulsation of the left ventricle as it moves anteriorly during contraction and contacts the chest wall. Palpate using the palmar surface of several fingers to confirm the characteristics of apical impulse. Now assess the location, diameter, amplitude and duration of the apical impulse. If you cannot identify the apical impulse with the patient supine, ask the patient to roll partly on the left side into the left lateral decubitus position. Next, feel for the right ventricular impulse at lower left sternal border. With the patient supine and the head elevated to 30 degrees, ask the patient to exhale and briefly stop breathing. Then, place the tips of your curved fingers in left, third, fourth, and fifth interspaces to palpate for the systolic impulse of right ventricle. In patients with an increased anterior-posterior diameter, ask the patient to inhale and briefly stop breathing. Palpate for right ventricle in the epigastric or subxiphoid area. With your hand flattened, press your index finger just under the ribcage and up toward the left shoulder to assess any right ventricular pulsations. The pulmonic area is situated in the left second interspace. This interspace overlies the pulmonic artery. As the patient holds expiration, inspect and palpate for pulmonary artery pulsations and transmitted heart sounds. The aortic area is situated at the right second interspace. This interspace overlies the aortic outflow tract. Palpation has replaced percussion when estimating cardiac size. Starting well to the left on the chest, percuse from the resonance toward cardiac dullness in third, fourth, fifth, and possibly sixth interspaces. Auscultation of heart sounds and murmurs is a preeminent skill that leads directly to important clinical diagnosis. It is important to understand the uses of both diaphragm and bell. The diaphragm is better for picking up relatively high-pitched sounds of S1 and S2, the murmurs of the aortic and mitral regurgitation, and the pericardial friction rubs. The bell is more sensitive to the low-pitched sounds of S3 and S4 and the murmur of the mitral stenosis. In a quiet room, auscultate the heart with your stethoscope with the patient's head and upper chest elevated to 30 degrees. Start at either the base or apex, listening first with diaphragm and then with the bell. Move the stethoscope from the point of maximal impulse medially to the left sternal border, superiorly to the second interspace, and then across the sternum to the second interspace at right sternal border, stopping at 6 listening spots. Alternatively, you can start at the base and inch your stethoscope to the apex. With your stethoscope in the right second interspace close to the sternum, move along the left sternal border in each interspace from the second through fifth and then towards the apex. Ask the patient to roll into the left lateral decubitus position, which brings the left ventricle closer to the chest wall. Place the bell of your stethoscope lightly on the apical impulse. Ask the patient to sit up, lean forward, exhale completely, and briefly stop breathing after expiration. Pressing the diaphragm of your stethoscope on the chest, listen along the left sternal border at the apex, pausing periodically so the patient may breathe.